So chapter 12, let's jump into what this chapter is about, what it means for the healthcare finance realm. This chapter will focus on two programs, one being the electronic health record and meaningful use. And I'm just flipping through the chapter as usual, and I'm going to read and review what I think is important. So the electronic health record is the first aspect of this chapter. There's an introduction paragraph section. The definitions of an electronic health record and electronic medical record are listed on page 206, and there is some difference, so familiarize yourself with that. A qualified electronic health record is an electronic record of healthcare-related information on a patient that includes all pertinent components of a medical record. And I don't know if you remember this from the beginning, but the medical record should include demographics, which is the patient's address, age, birth date, race, ethnicity, insurance, etc. Tons of information in the demographics. This also includes the history and physical examination, clinical information that allows other clinicians, not only the provider, but the other people involved in their care to make the information. All that is included in an electronic record, along with computer physician order entry, CPOE, the ability to capture and query information in the health record and transmit or exchange information to other sources. And there's a citation there for you. But so the electronic record is more than just scanning pieces of paper or more than just entering in vital signs. It's a huge arena of responsibility, information, etc. Vision and benefits of an EHR system. You guys can read that chapter, but overall, it should improve quality, enhance patient safety with reminders and alerts, support health maintenance, preventative wellness care, increase productivity through efficiencies and workflow support, reduce some of the slower process and manual systems such as registration and documentation, supports revenue enhancement through eligibility verification, and support evidence-based healthcare, maintain patient confidentiality, and exchange the information. Those are all so very important. I don't know if any of you, with whatever doctor's office you visit or healthcare system you're a patient for, if you've ever had a chance to interact with MyChart, that system is portable or transferable, so you as a consumer, a patient, can log on, send your doctor a message, or even book your own appointment, and they can converse with you also. And that type of EHR communicates with the given hospital system or the given doctor's office, whoever pays for it. All that information's in there. And it does. It really does improve quality, improves communication. You get reminders about appointments. You get reminders if you need a flu shot, that sort of thing. So it's a very good thing. Components of the EHR. There are four main categories of an electronic health record. Source systems that collect data, core clinical systems that enable the use of the data, and I lost my place, hang on. Supporting infrastructure that integrates the data, and connectivity systems to help to integrate data. That's in the middle of page 207 on the left-hand side. The right-hand side of page 207, point-of-care charting systems. They're also known as clinical documentation systems. These are very important. As a nurse, I've used many charting systems, whether it was in the operating room, the emergency room, the units. And believe it or not, more so lately, I guess, but 20 years ago, these charting systems did not communicate with each other. So it was quite challenging. But now I believe most hospital systems have a system called Epic that they use, that they do communicate a little bit. It's not perfect, unfortunately. All right. So the second part of this chapter is meaningful use. Why do we do the electronic health record? What are the values of it? CMS has created an incentive program that will provide financial incentives for the meaningful use of a certified electronic health record for Medicare and Medicaid providers. I'm going to flip over to 208. And there's the very first paragraph on the left-hand side. Meaningful use is where a provider uses that certified EHR system to improve quality, safety, efficiency, and reduce healthcare disparities. There's also, it's not written here, but overall too, the use of electronic health record, if it can save money, that's a bonus too. But most importantly, our patient outcomes would be the biggest priority in moving to an electronic health record. The chapter continues meaningful use to eligible professionals, what it means, participation, and other CMS programs. Page 209, it goes into incentive payment calculation and time frame. So it's important to know the little rules and expectations, if you will. If an eligible provider uses the EHR, there's an incentive payment equal to an annual limit of 75% of that eligible provider's Medicare physician fee schedule for a calendar year. The eligible physician can also file claims from the previous year for up to 2 months after December 31 of the year before. Read that and pay attention to that and make sure you understand. If you have any questions about that, let me know. But if the patient is seen on December 31st, that eligible provider has 2 months to file claim for that previous year. I hope that makes sense. Maximum incentive payments are reviewed. Meaningful use stage 1. So there are different stages, and I am not going to read all of these to you. You do want to learn them. You do want to know them. I would suggest either good old-fashioned flashcards, note cards, or even setting up something in Quizlet, or maybe a student ahead of you has used Quizlet for this particular chapter in this book. But the meaningful use stages are important, especially the core objectives. For example, the first core objective on page 211, using the CPOE. This measure requires that the EPs have more than 30% of all unique patients have at least one medication on their medication list. That's a little quirk or a little rule, if you will. And then number 5 says the EP must provide more than 50% of all patient requests for an electronic copy of their medical record within 3 business days. So that's an important thing to note. Number 6, number 8, 10, 12, they just keep going. Menu objectives for EPs, stage 1. Again, I'm not going to read all of this, but there's very valuable information in these. Meaningful use stage 2 on page 215. Definitely review that. And again, the objective stage 2 continues. Menu objective stage 2 on page 219. And then towards the end of the chapter, page 220, clinical quality measures, stage 2. For the EHR incentive program, an EP must report on 9 clinical quality measures out of the possible 64 approved. That doesn't sound too bad. And there's something important to know too. The 6 domains of patient and family engagement: patient safety, care coordination, population and public health, efficient use of healthcare resources, and clinical processes and effectiveness are what the Department of Health and Human Services considers priority for quality improvement and quality outcomes. And then there's a nice conclusion. So basically, the electronic health record, when I was a nurse and we were used to write on paper and document everything on paper, when we transitioned to the electronic health record, it's very challenging, but the outcomes have improved. Indeed, and it'll be interesting to see where we are 20 years from now with the improvements and the ease of communication and sharing this information, and even taking data from it, researching and improving outcomes that way.